has transformed field of ophthalmology, especially for retina surgeons. It was a big role. And more than any imaging modality, OCT is being used frequently. It is used in high resolution for anatomical details. Also, its rapid acquisition, its non-invasive nature has changed a lot of things. And it is just, we are lucky to have such imaging technique, which is said to be very safe. Without taking much time, I'll introduce you to a very young, energetic Vitreoretina Surgeon, Dr. Jibat Gemida from Menelik II Hospital. And I welcome Dr. Jibat, and I'll pass this stage to him to really go on and teach us, give us highlights, details about optical cones tomography principles and technical pills. Welcome to this platform, Dr. Jibat. Stage is yours.
Thank you, Dr. Sadin. Good evening, everyone. Today we'll discuss on the basics of macular OCT. We will not discuss about OCT angiography and other OCT applications. So I don't have any financial issue to disclose. So my outline I will discuss on physical principles of OCT. I will discuss on quantitative, qualitative analysis of OCT, what are scan protocols, normal macular anatomy nomenclatures, and I will discuss on artifacts and what are future direction concerning OCT. So OCT is a non-invasive, non-contact imaging modality that produces a micrometer resolution image of tissue. So the first report on the clinical application of OCT image of human eye in vitro was published in 1990. This was done from tissue collected from the eye bank. So when you see a timeline showing the evolution of various types of OCT, you know, the concept was started in 1971, but the first OCT image was captured in 1991. It was in vitro retina image. Then in 1996, first commercial ophthalmic OCT device was came to the market. So lastly, in 2014, OCT angiography was invented. So the advantage of OCT is it is quick, non-invasive, and it is reproducible. So the principle is, you know, low coherence infrared light is directed into tissue and reference arm. So an interferometer combines the light returning from the tissue and the reference arm to produce interferogram. This is called Michelson's interferometer principle. So what will happen is there is a light source projects beam to the beam splitter. So the beam splitter projects light to the reference arm and the tissue, so that light reflected back from the reference arm and the tissue will be captured by the detector. So why does the light reflect back? Because of the difference in the refractive index of the various layers of the retina. So when you see the generation of different types of OCT, you know, there are two main ways in which the backscatter light can be detected: the time domain, which is first generation OCT, and the Fourier domains. The Fourier domains has two OCTs: the spectral domain, which is the second generation, and the swept sort OCT. So during the first initial period time domain, you know, the image resolution is not as such good, and the speed of image acquisition is not that much fast. And there were, you know, issues with artifacts. So when we see the comparison between time domain, spectral domain, and swept source OCT, you know, the most important difference is image acquisition speed. With time domain, we can capture around 400 A scans per second, while with swept source OCT captures around 100,000 A scan per second. So in general, when you see optical imaging resolution comparison, the resolution power of the OCT as compared to other imaging modality, it is better than CT ultrasound, better than scanning laser ophthalmoscope, adaptive optics scanning laser ophthalmoscope, and it is comparable with confocal microscope. So OCT analysis is, basically quantitative or qualitative. Quantitatively is there are inbuilt software in OCT devices that are capable of, analyzing the thickness of the retina, individual retina, and a macular volume, while qualitative interpretation reviews individual line scans of the image retina and assess the pathology on the basis of the knowledge of the normal retina. So the scan protocols, mainly there are 3 scan protocols, the macular, the radial scan, and the line scan. But with the spectral domain OCT, there is also EDI, enhanced depth imaging, to visualize the choroid. So in macular cube scan, it's basically a rectangular box 6 by 6 or 7 by 7 or 12 by 9 millimeter. It captures the topographic maps or the macular volume. With radial scan, it consists of multiple lines which passes through the fovea and arranged in equal angles. And this may differ in length, density, and resolution depending on the OCT system we use. The raster scan, these are a series of parallel line scans that can be oriented in any angle, and this has got higher resolution. Especially raster scan is important to capture, through lesion OCT. So the image appearance is mainly 2D appearance, but you can, capture a 1D scan or a 3D volumetric scan. So the normal macular anatomy of OCT images, it is called in vitro optical biopsy. The layers in the OCT is correlate with the histological feature of the macula. So you can, visualize the detailed cellular structures of the macula over the OCT. So in 2014, an international panel of experts, gathered to reach a consensus for OCT imaging technology. So in general, they give a terminology for 18 layers starting from the posterior cortical viscera to chorioscleral junction. So based on reflectivity, the retina and choroid layers are divided into zones and bands. Zones are those areas of retina that cannot be easily distinguished by clear-cut margin and lack proven histological evidence, while bands are areas with discrete and well-defined and have proven histological correlation. So zones can be further classified as hyperreflective zones and hyporeflective zones based on the nature of the reflectivity of the layers, and the bands or the layers also classified as hyperreflective or hyporeflective layers. So the most important area in retinal imaging is the outer retinal hyperreflective layers. These are called the photoreceptor integrity lines. So there was, controversy in nomenclature of especially the last 4 layers of the outer retina, and especially the layer 13. Initially, it is called photoreceptor outer segment tips, but later in 2017, it was said it is part of the apical part of the retinal pigment epithelium, which phagocytoses the photoreceptor disc fragments. But still there are controversies going on. But, during reading the OCT, you need to see clearly the 4 hyperreflective bands of the outer retina, because that can, give a prognosis of the vision. So the abnormal reflectivity we'll discuss later. Either it can be reduced reflectivity or increased reflectivity. So the last is OCT artifacts. This could be patient-related, operator-related, or software-related. But artifacts were common in the era of time domain OCT. But nowadays, with swept source OCT, these artifacts are relatively minimal. So the first artifact is a mirror artifact, which is caused by eye position incorrectly or scanning a large depth range in like bullous retinopathy, retinoschisis, or myopic maculopathy. So what you find is an inverted and a poor resolution image. So what you can do is you can do a rescan. So the other artifact is the vignetting effect, where there will be loss of the signal over either side of the OCT. This is because of being blocked by the iris or undilated pupil. So what you can do is you can reposit the OCT machine. The other artifact is misalignment, which is caused by a scan which is not centered on the fovea. So how to identify is fovea is not aligned with the center of the ETRS macular grid. So you can, you can manually correct this, or you can do the rescan. So the other artifact is software breakdown. This is caused by misidentification of either the inner or outer retina. And what will happen is, especially on the macular map, you will see a bow tie appearance, or sometimes you find finding inconsistent with a clinical picture. So how, you can correct this by manual correction of segmentation or error, or you can do a rescan. So the other artifact is a blink artifact caused by patient blinks during OCT image acquisition. So there will be area of dropout, and how to correct, you can do a rescan. So the last error is out of range error. A B-scan is vertically shifted out of the scanning range, and there will be cutoff of the top inner retina or the bottom outer retina part of the OCT. So the correction is you will do a rescan. So what are future direction related with OCT or advances in OCT? One is, with the swept source. Nowadays, there are wide field swept source OCT. Even you can capture the whole eye OCT, as you see on the picture. The other is, there are nowadays, different biomarkers for different diseases in PT, like in diabetic macular edema, in pachychoroid spectrum. So the other is in-fast OCT, in-fast of the different layers of the retinal layers. Other advancement is adaptive optics OCT. This type of OCT is especially, advanced in visualization of each cellular structures of the retina. So the other advancement is enhanced vitreous visualization, and the other is Octa. Octa came to the field in 2014, but nowadays there are wide field Octa. The new development in OCT is intraoperative use of OCT. Nowadays people are using routinely intraoperative OCT. And the last is artificial intelligence and deep learning, especially, to give prognosis or the outcome of treatment for different diseases in TT. The biomarkers are included in artificial intelligence and deep learning, so that you can prognosticate the outcome of the treatment. Thank you.
Thank you, Dr. Jibat, for your very precise presentation. And hope there will be some questions on the chat. Next will be Dr. Dereje Nigussie, another Vitreoretina surgeon from Addis Ababa University. He's assistant professor of ophthalmology in Addis Ababa University. And he practices also in Nisir specialized eye clinic. Dr. Dereje, the floor is yours. And please tell us how to interpret the retina OCTs. Thank you.
Okay. Good evening, everybody. Thank you, Dr. Sadin, for your nice introduction. Thank you, Dr. Jibat, for your class on the filters and OCT. Now I'm going to start real life CT. As you all know, these days we do have an OCT in Ethiopia, especially in Addis. So most of our ophthalmologists are now started to practice.
Dr. Dereje, we cannot hear you. Dr. Dereje, can you hear us?
He's trying to rejoin.
Can you hear me?
Now we
Hello.
can hear you. Yes.
Can you hear me?
Yes, now yes.
Okay. On our presentation today, this is my outline. I will discuss on the guideline of OCT, and then I will have some cases to discuss. In the meantime, while we are discussing, someone want to answer questions and the like, he can raise his hand on the chat box. So before we go to the disease entity, I think it was discussed well with Dr. Jibat, that we should know the normal anatomy, how it's like inner flexible, outer flexible. All this layer should be identified before we go to
Yam? Yummy? May.
So, in we diagnose different problems, while areas which are affected by specific types of disease, these retinal pigment epithelium and around the photoreceptors are mostly affected by these arising from the quick, like choroidal vascularization, which arises from the choroidal as a complication of age-related macular degeneration. This area, the inner retinal layer, is mostly affected by retinal vascular disease, including diabetes and retinal vein occlusion. So
Hello, Dr. Dereje.
Sorry, Dr. Sadin. There is instability in internet around here.
Yes, okay, okay. I just lost contact with you, so I don't think the others are also hearing you. So
How about now?
really good now.
Okay. So in OCC assessment, I would like to follow this guideline, which I found is very important. So we'll go through this one: infrared image, scan quality, scan location, and cross-section of the retina for diagnosis of each problem. So when we say infrared image in assessing the retina, there are different types like retinal football hemorrhage. If we see like dark spots, it can be intraretinal hemorrhage or microaneurysms. Brighter areas, those area of atrophy. The bright spots can be exudate, pigment alternation, or drusen. When you go to the scan quality, always you have to comment on the quality of the scan. By that, whether the media opacity affects your scanning on the light. Some machines gives a number, the others they gives evaluate signs to noise ratio, and then they said good, noisy, or insufficient, or the other with number. If it is greater than 40, might be a good quality, so that you can interpret findings properly. If quality is not good, you cannot see most of the intraretinal lesions properly. The other important thing, knowing the location of each anatomical area of the macula is quite important. Sometimes you might see hyperreflectivity at the center of the fovea. We call it foveola. This is because of light ray that hits the axon at the right angle, gives this hyperreflection. And at times you might see foveal bulging. This is not pathological. Rather, it is high density of cones in this area, gives like a kind of elevation, might mimic a kind of subretinal fluid. Then, when you say this is the foveal depression area, and this one is the macula, so when we take the thickness, we take from the internal limiting membrane up to the retinal pigment epithelium, and this is the thickest area is the maculopapular bundle area, which is near to the disc, and it is quite important to differentiate whether it's the right or left eye. It is not written on the scan. The other important landmarks and location is knowing areas, so that by knowing area, we can diagnose different diseases. So I'm going to discuss depending on areas, then specific disease happening. The area which is found below the RP, we call it sub-RP space, and the retina, the space is above RP and below the photoreceptor here. This is called subretinal space. And the area from internal limiting membrane up to the edge of RP is called intraretinal space. And this is outer retina. The inner retina is outer plexiform layer is a border. And this is one beyond the outer plexiform layer, we call it outer retina. If any lesion is sticking to the retina, we call it epiretinal. And if there is small space between the internal limiting membrane and the structure which is developing, we call it pre-retinal. So knowing all these anatomical areas is quite important to list out different differential diagnoses. So depending on the type of structure we have, the reflectivity also matters. Like outer nuclear layer and the inner nuclear layer appears hyporeflective, as you see here. And outer plexiform layer and the ganglion cells layers appear medium reflectivity, as you see here. And the retinal pigment epithelium and the retinal nerve fiber layers appear hyperreflective. The signal-free areas are like vitreous, where there is no any reflectivity. When there is a fluid, that shows signal-free. So cross-sectional scanning assessment, when you assess retina, you have to, after completing assessing the infrared image, that means each type of infrared image reflects a pathology. Then you have to start to assess from retinal pigment layer, sub-RP layer, sub-retinal layer, intraretinal layer, EP, and pre-retinal layers. So I will go one by one. What happens if sub-RP or sub-retinal pigment epithelium or retinal pigment epithelium have a change? Like if it is elevated, either it is pigment epithelial detachment or a shallow irregular retinal pigment epithelium elevation, we call it 6. So it is this, if this one is elevated, homogeneous, or it can be black, that means serous fluid. If it is bit hyperreflective, it might be drusoid. Heterogeneous can be kind of fibrovascular detachment. So RP can be interrupted. This can be a sign of retinal pigment epithelial rip or atrophy. So when you find a scan of a patient having such a finding, like for example, this patient is having a single hyporeflective material sub-RP, it is a kind of single drusen or drusenoid retinal pigment epithelial detachment. But sometimes you can have medium reflective confluent drusen. Still, it is a sign of drusen. Or you might have a single hyperreflective drusenoid material are under the RP, or a patient might have this undulation, different types of elevation that you find like different level of pigment epithelial detachment is called multiple drusen. In such a patient, you will not find a fluid. There is no any activity showing a kind of CNV. So such a patient is having drusen, which needs follow-up. There is no treatment. But you might find having fibrous changes with different level of reflectivity, hyperreflectivity, meaning this patient is having choroidal neovascularization that disrupts the retinal pigment epithelium and the Bruch membrane. This is a kind of active choroidal neovascularization who is having subretinal fluid. This is a patient with neovascular remedy that needs most likely treatment, but it can develop from other causes like trauma, inflammation, degenerative tumor, or idiopathic causes that can lead to development of CNV. So this is fibrous because of this hyperreflectivity gives you such a finding. But a patient serous fluid under retinal pigment epithelium, and you count the differences. This one has kind of drusen, it's like low AMD origin, but in this case, in such a case, differentiate between the two, you have to find of the your slit lamp examination, what have you. But sometimes you might have shallow irregular retinal pigment epithelial elevation. That means you can see clearly the Bruch membrane and the retinal pigment epithelium. So if this line has kind of fluid, it might be a sign of active macular neovascularization. If not, the one this white one, you might not need treatment. Patient can have also atrophic change. So it's a progressive loss of photoreceptor, retinal pigment epithelium, and chorocapillaries. So you will see such hyperreflective or transparent, high transparency. So the choroidal background is visible clearly. So currently in 2020, there are two types of classification for this, incomplete and complete. When you say incomplete, the size of the atrophy is less than 200 micron when you measure from size of atrophy from here to here. And if the size is greater than, this one is almost greater than 500 micron, we call it complete retinal pigment epithelial outer retinal atrophy. If the size is less than 250, we can call it incomplete. You can see here, patients come present to you with bare macula. There is nothing here. You cannot see retinal pigment epithelial in the background. On OCT, it's already thin. This is one of my patients so recently. You see, if you see the center of the fovea, it's quite white. And here you will not appreciate any neurosensory retina. Almost the retina comes fixed into the retina pigment, completely atrophied retina with the thickness almost less than 50, 60, and the patient is having poor vision. Such a patient doesn't benefit from any treatment. You might give them some supplement. Otherwise, just such a case will not benefit from injection or other treatment. So, what do you see here? Anybody? Here. What do you see here? Sorry? Anybody wants to comment? No, I will continue. This is it's a big defect that you see here. This is a photoreceptor inner outer segment complex is lost. This mostly happen following photocoagulation effect, and that is most likely of solar retinopathy or from any laser spot damage. So this patient loses photoreceptor layer here. Next is I will discuss about subretinal area. In the previous discussion, I discussed the subretinal delusionoid deposit, or they can have subretinal hyperreflective material, which can be associated with subretinal or intraretinal fluid, which is a result of choroidal neovascularization, or hyperreflective material can be solid. So in this case, a scar from end-stage AMD, or sometimes vitelliform dystrophy can give such hyperreflective subretinal material, or subretinal fluid can be found here in subretinal space. This can be from exudation, or from traction effect, or from retinal detachment. You can see fluids. So subretinal hyperreflective material, as you see here, this is the subretinal hyperreflective material. So this results from choroidal neovascularization, and this type of macular neovascularization from AMD. You can see such a lesion just under subretinal space. So this can be this subretinal space having also subretinal fluid. If you find such a lesion beneath the RP, we call it type 1 macular neovascularization. If you find such hyperreflective material above the RP, this is RP, above the RP, which is shown by a red arrow, it is type 2. And sometimes you might find intraretinal, this is type 3, and this is types of choroidal neovascularization that you might find in subretinal space, intraretinal space, and subretinal. This is sub-RP, this is subretinal, this is intraretinal. This is to show you how different lesions happens in the layer of the retina. So you can see there is a change. Subretinal space, this is hyperreflective material, but it's having regular edge. If you compare with the slide down there, there is a big difference. This is irregularity with fusiform or amorphous pattern. It's most likely of active choroidal neovascularization, but it is consolidated and it is hard. It's an old one. So as a result, the case with amorphous or irregular pattern of subretinal hyperreflective material is likely to benefit from anti-VEGF treatment, but this is old scar, they may not benefit from treatment. So this is amorphous again. It is quite important for evaluating a patient with AMD. You see the edge is not well delineated and regular, but when you compare this one with this one is consolidated. So this is quite important to differentiate for the treatment purpose and diagnosis of active or old CNV. For you, if you can you differentiate which one of the two is amorphous, which one is consolidated from the two slides? The one above, what is this one? Is it amorphous or consolidated? Anybody can try this?
The upper looks amorphous, the lower looks consolidated.
Yes, thank you. Correct. So this is an active CNV and with fluid, and the patient is likely present early, may benefit from our treatment. This one is a scar, less likely to benefit from our intervention. How about now? The first one? Okay. This one is consolidated. The second slide is amorphous, and these are active CNV. This one is annulled with scar. What do you see? What's the different things that you see between the two eyes, between the right and the left eye? This is a fundus picture with OCT finding, and also fundus picture with OCT finding. Which one is an active one? Which one is inactive with scar that can benefit with our intervention? Anybody who can comment on this?
Right one is active, the left one is scar gone.
Yes, this one is active CNV with subretinal fluid, as you see here. This one is, as you from the fundus picture, you can see this keyform scar, and it is a solid hyperreflective material in the RP layer. So this is scar patient will not benefit from any intervention. So at the end of your treatment, patient present with CNV with subretinal fluid, and then you treat fluid with dry, but they will end up with small size CNV scar. So we cannot prevent scar, but we can treat and minimize the degree of scar of CNV after our anti-VEGF treatment. The other thing, you can have subretinal hemorrhage. This hemorrhage most likely develop from rupture of choroidal neovascularization, and it gives you such hypo-reflectivity. As a result, this patient also give a blockage of visualization of the underlying choroid. So sometimes clinically patient present with extensive macular hemorrhage, especially aged people, without any trauma or having any non-system, there is no history of diabetes or hypertension, but they develop such aggressive. First line, you have to think of choroidal neovascularization from AMD, so they benefit from anti-VEGF. But you can still have fibrous scar in the subretinal area. This is extension of sub-RP scar, comes into subretinal space, and the patient with extensive disc growth scar, you can appreciate on OCT extensive hyperreflective material where there is no fluid. But sometimes these are another type of hyperreflective material. It's called vitiliform dystrophy. This is due to photoreceptor layer accumulation of the leukocyte material byproduct. As a result, it's new hyperreflective material. In such a patient, they will have a better vision, unlike that of a patient with this form scar, which has having a vision of count of finger in front or 1 meter. But this patient can have a vision up to 624 or 680 because the photoreceptors layer is still functional, even though pushed by the deposits. So in this case, clearly you see that this is a subretinal space having a fluid. This is the one which you see with the star. It is the subretinal space. If you find a fluid like this, you have to look for differentials that can cause such a fluid from your history and the physical examination and the like. In the subretinal space, fluid can develop, as I have discussed on the graph. It can be from the fibrous scar from AMD leading to leakage, and the patient will have fluid, or vitreomacular traction causing a kind of fluid in subretinal space, or a patient with retinal detachment likely to have accumulation of fluid in the subretinal space. All these things can be nicely appreciated by your OCT. Even after treatment, you can appreciate improvement. So to differentiate clearly between the two, this one, the blue stars are clearly subretinal fluid, but the one with red arrow is sub-RP fluid. So fluid that develops sub-RP is most likely of AMD origin. Still, it can be AMD, but other differentials is there. So knowing areas where things are involved, quite important to list out possible differentials. The other problems that can happen is intraretinal. In the intraretinal can be thickened from edema or from small fluid accumulation, or hyperreflective material or spots can be there in the outer retina, or in the inner retina. In the outer retina, mostly pigment migration or cellular debris. In the inner retina, hard exudate or thin accumulation of lipid material. Or intraretinal hyperreflective material can be different size, medium reflectivity or medium to hyper. Depending on the reflectivity, you can diagnose microaneurysms, macular neovascularization, or scar. Sorry.
Hello, Dr. Dereje.
Hello, Dr. Sadin.
Yes, you are back
Dr.
now.
Sadin,
Yeah.
I'm
You are
back.
back. Continue, please.
Some problem here, I don't know.
Yeah. It's okay. Continue.
Okay. Intraretinal fluid accumulation is a serous fluid within the retina. As the intraretinal fluid spread across the macula, it's likely to give a thickening in the macula to result into square macular edema. You might have single intraretinal fluid which results from a local area of retinal degeneration. So CME is likely recognized OCT by its own uniform appearance, hyporeflective cavity within the retina, and its increased retinal thickness. So this cystic cavity is likely to have gray than black appearance. It's most likely from fibrin, high molecular protein, or highly material accumulation. So as you see here from this picture, you can have fluid, different size of fluid in the intraretinal space, and some subretinal fluid. This patient is a kind of patient with bright retinal vein occlusion, and prominence of the middle limiting membrane, which is a sign. If it is prominent, and if you find the prominence of middle limiting membrane on your finding, show you that there is arterial obstruction causing arterial ischemia, and this patient is likely to have poor vision even after injection, and likely to develop even neovascularization later on as a complication. This is cystoid change in the center of the macula and the foveal area, this cystic cavity, and there are some intraretinal fluid. So this type of CME or cystoid macular edema. And this is a kind of, this above one is a patient additionally having a finding like hyperreflective material in the intraretinal space. So this goes with most likely of different signs of hard exudate. But you see lesions down there, intraretinal fluid, multiple cystic space with subretinal fluid, but there is no such marked hyperreflective material. It goes with Irvinga syndrome or CME following cataract surgery. This is the way that you differentiate, and also proper fundus finding helps you differentiate between cystoid macular edema from DME and from post-cataract surgery, because the treatment is quite different between the two entities. The other one is hyperreflective material. these are intraretinal hyperreflective material, as you see here. This is a kind of hard exudate and also a prognostic indicator in a patient with DME. But sometimes you might have a small hyperreflective material in the intraretinal space. These are small lipid accumulation, or you might find drusens, some hyperreflective material above the drusens. This might be a migration of some pigment cells that is not as such pathological. And at times you might find hyperreflective material in the photoreceptor layer that is kind of cellular debris. So you have to differentiate different hyperreflective materials. Some are good prognostic indicators, some are some physiological that might not be indicator of seriousity of the problem. You might find hyperreflective material like this. This is using the intraretinal layer. So this is type 3 macular neovascularization. So this is might benefit from anti-VEGF. And you might find also intraretinal hyperreflective material, which is over a kind of microaneurysm that leaks and gives you such a cystoid swelling or central cystoid edema, fluid accumulation. You can see sometimes intraretinal hyperreflective spot here at the edge. This is most likely of intraretinal hemorrhage, or you can find such fuzzy pattern, irregular pattern at different locations of larger size, involving almost the whole layer of the retina. This is most likely of infarction of the nerves, neurosensory retina, that's called cotton. So it's quite different. Hemorrhage is quite above. This one is infarction involving almost all layers of the retina. By that you can differentiate between them. Sometimes there are some things that which is not pathological, but it can be taken as an artifact. Helium fiber reflex artifact happens a medium reflective thickness of outer flexiform layer, and it can be missed as a pathological or alteration. This is something which is normal. This is helium fiber layer reflective artifact. You can see both in these two slides. So because it happens, the light incidence of light beam from the OCT hits the helium fiber layer at a certain angle, the result such a reflectivity, not pathological. So knowing pathologic change and the normal change is quite good to reach to diagnosis. Such cases, they will present to you with diffuse hyperreflectivity of the internal layer, and this due to central retinal artery occlusion. There is no any sign of fluid, even in the subretinal space, even in the intral space, but it's diffused opaque. It's due to occlusion, central retinal artery occlusion, causing diffuse edema of nerve fiber layer. You can see also from a periretinal membrane this disorganized layer. You cannot differentiate different layers of the retina, like nerve fiber layer, the ganglion cells, the optonuclear layer, and the like. This is called drill. It's a poor prognostic indicator for intervention of a patient with surgery or anti-VEGF once they do develop this drill. What do you see here? Yes, as you see here, the right eye is quite normal, but the left eye is having thinning of the nerve fiber layer on the temporal aspect, including the fovea. This patient is having very poor vision, maybe counting. I saw this patient recently, and with real unknown cause, maybe it's an old central retinal artery occlusion or branch retinal artery occlusion in the opposite of you. So, 60 years old lady presented with left eye visual most loss, and her vision was 20/30 in the right and hand motion in the left, with a diabetes of 29 years and hypertension of 21 years. On fundus, you can have this fundus finding. On the right eye, as you see, there are some hard exudates over here. The left eye, the problem is here, pink disc, having hard exudate and such finding. What is the likely diagnosis of this patient? Anybody who can try? Can you see the picture, Dr. Sadin?
Yes, the picture is very visible. Yes.
Okay. Can you invite anybody can try on this possible?
Anybody can
different-
unmute and respond to this question, please.
If not, I will continue. This patient is having, as you see here, diffuse thickening of nerve fiber layer, and there is whitening in the inferotemporal quadrant and involving the macula. So she developed a central retinal artery occlusion, and that's why she has such poor vision. It's not something edema that needs injection. As you see, there is no fluid, but thickening of nerve fiber layer. The inner layer is diffusely thickening. As you see, toward the fovea, it's become more thinned and atrophied. And this central retinal artery occlusion may be duration of weeks, not acute one. This one is another important slide. Still, I will invite our colleagues to comment on this slide. This patient is a 65 years old type of patient having 1 month history of visual loss on this eye. And then have a look on this and what is the diagnosis and possible intervention or any other thing recommend on this slide. Anybody interested to comment on this? No, Dr. Sadin? Anybody wants to comment on this?
Yes, I can hear you. Yeah.
Yeah, anybody who comments on this?
Macular or
Did you
Macula?
have a laser? Did you have a laser treatment?
No laser treatment. Patient present with visual reduction, almost loss, and picture of the OCT shows like this. Printout. Anything further investigation you want to do or further comment you want to give on this scan?
Looks like intraretinal cyst, but it
Infrared.
could be also somewhat macular hole, which has maybe VMT, which was separated field. Anything differential could be more, but there are cysts.
Okay. Okay, I will go for the next slide and you will appreciate, okay? And then what happened? Follow this video, please. Yep. Have you seen now?
Then it's macular hole, which was
Yeah. So what I will recommend for any one of us who are having a chance to practice with OCT, don't rely only on the printout of OCT. Rather, you better go to the OCT machine and try to scan like this. I usually don't accept the printout. I will usually go to the machine and look the scan rather than look out the printout. This is the difference. Here is the hole. But if you believe the previous printout, you might go for injection. But if you do scanning, you will appreciate the hole and then you will treat accordingly. Okay, this patient will benefit from surgery rather than injection. The other problem you might find is EP or preretinal area. So on the EP or preretinal area, you might have a preretinal membrane or posterior hilar separation or traction, foveal disruption or preretinal neovascularization. Sometimes vitreous opacity can be appreciated. So this is a patient is having macular pucker. You can appreciate on OCT a membrane traction effect with subretinal fluid, and drill, where there is no separately appreciated nerve fiber are not well appreciated. So this is a periretinal membrane. This is a hyaloid membrane is detached with a still adhesion at the foveal area. We call it vitreomacular adhesion. It depends on the force and capability. At times, patient can have complete separation, or they might end up with macular hole, depending on the force there. So if that vitreomacular adhesion strong enough, it can take the whole foveal tissue and the patient develop full macular hole, or sometimes leaves without causing any hole. You see, complete vitreous detachment without any hole, but here it causes a hole while the vitreous posterior halo separates from the lateral. You can have also a periretinal membrane with hyperreflectivity here and partial macular hole. Such a patient will have a good vision. I saw recently a professor having such a finding, but his vision is still 20/30. Even he didn't notice that having a poor vision, so his partial macular hole less likely to cause like distortion or visual reduction, intervention depending on the visual demand and visual reduction. Vitreomacular traction, when it pulls up the inner retinal layer, can cause a kind of space here like subretinal fluid. Such patient will not benefit from, depending on the cause. The releasing of this traction might relieve traction and the subretinal fluid will disappear, or if it originates from other causes, you might combine treatment. Hole, sometimes you can happen like this from the membrane, and so OCT is quite important and beneficial. It's really important to diagnose a problem like this macular hole. Even you'll see treatment outcome after treatment, that closing of the hole after treatment. So you can easily explain to the patient. Your patient can easily believe you and then understand his problem. For intervention and decision, quite life is easy as compared to maybe from the pre-OCT era. No, patient can benefit from injections, and then they can have resolution of all subretinal and intraretinal fluid and appear like this, and edema completely resolved. And then you can appreciate from your OCT both quantitative and quantitative. You can assess how much the thickness decreased from the original edema and the like. And even you can try treatment after getting proper interpretation and diagnosis of macular problem. This patient is having vitreomacular traction with intraretinal membrane and a kind of subretinal fluid. And after relieving of this vitreomacular traction and the removing of periretinal membrane, the patient is having such regular contour of retina. The scanning was not good because the center was not well delineated, but I operated this patient 2 months ago and the vision is good now. So when you follow your patient, for example, this patient is having such atrophic change on the macular foveal area, and when you scan this patient, you can have such intraretinal layer is not well delineated with the periretinal membrane, retinal hyperreflective material, the kind of neovascular remedy was on anti-VEGF for a long period of time. So this patient present to me after 3 months, and then when you see the fundus, almost is the same. But it should be a good trend that don't believe only on your fundus finding. Better to scan your patient every 2-3 months. You might find a finding. So this patient is having a fluid like this. When you see the fundus finding, almost the same, but those is quite different. So in follow-up, it should be a part of regular scanning of a patient in order to identify some fluid which is not detected on our slit lamp examination. So the beauty of OCT, this one of my patients having a scar, but it looks like flat on our biomicroscopic examination. But when you do OCT, it has hyperreflective material in the subretinal space with extensive intraretinal fluid. So such a case might be a candidate for further intervention. At last, please don't only rely on OCT. Always you have to have a good, take a patient history, evaluate a patient, and the clinical examination. And if necessary, you have to add fluorescent angiogram or ICG, and then OCT. Combine all these things, you have to reach into the diagnosis. I can share one of my patients. If such a patient is a kind of CSR, have subretinal fluid, but you have to do fluorescent angiogram, you will see area of leakage. So by your clinical examination, you might see dome-shaped raised macular lesion without any hard exudate or any other hemorrhage and the like. And the patient is maybe relatively young with laryngeal vision with metamorphosia. And maybe the vision is 20/40 or better than that. So after doing focal laser around here, the macula likely to become down with the resolution of subretinal. This is one of my case benefit from using multimodal and clinical and considering this of the patient and reaching to the diagnosis. So don't rely only on OCT. Please take into consideration all other possible parameters like history, examination, and FA, if needed, to reach it to final diagnosis. So at last, practicing a retina without OCT is like driving a car at night without a light. So this guys, our life is very easy because of OCT in diagnosing and treating retina. And in mastering all these things might take a time. We'll asymptote to mastering of such OCT reading and interpretation because there are a lot of challenging cases coming day to day in our practice. So you have to practice, and then you can master your OCT reading by interpreting and reading properly. You diagnose and treat your patient properly. Thank you.
Thank you, Dr. Dereje, for a very nice presentation, very clean slides, very informative slides, and really, I even got a lot from you. Thank you, Dr. Jibat, for very nice presentation. Now we'll go to question and answer session. We have a few minutes to go, so you can forward. You can unmute your microphone and please forward the question to the presenters. The floor is open for you.
Hello, Dr. Sadin.
Yes. Okay, Dr. Ababa. Okay, please continue.
Okay, thank you. Thank you, Dr. Jibat and Dr. Dereje. It's really very important, for all of us to know how to interpret and its clinical use. OCT is mandatory in our practice nowadays. So thank you so much. So my point is just for example, so as you have been describing to us, OCT has many artifacts. It requires knowing all the detailed structures of the eye and the pathology, the various pathology going on in the back of the eye. So, like for example, if we order like CT scan or MRI, we usually get print out of interpretation by experts. So we rely on that reading, on the expert comment. So for OCT reading, so those centers or the centers with OCT or the center with experts like you, don't you think we need OCT result to be interpreted by an expert? For example, if I say I send a patient for OCT, either to Dr. Dereje or to Dr. Sadin, what I expect is instead of just sending the print out of the OCT, I also need the interpretation. This is, this has been in my mind all the time. So what is your suggestion? Because interpretation is really, really important.
Okay.
Thank you.
Dr. Dereje, do you have any answer for this?
Yeah, Dr. Abba, you raised a very nice issue. OCT is mostly done by the optometrists or the technicians. And then usually they print out and send the picture to the physician for interpretation. Like we do ultrasound, we interpret the finding and send a report. In my center, what I do, I order the optometrist to show me all the findings, even from inside or from external, from the screen of the OCT. At times, they might not keep the center of the phobia, or they might notice some of the artifacts. And I was using to write comment on the OCT. But these days, because of maybe a burden and activities and a lot of patient management and the like, time constraint, I'm not doing regularly, but it's a good comment, accepted. I think I have to resume, at least from my side. Maybe my other colleagues also having OCT and practicing on OCT, such referral cases, even your own cases, don't rely on the printout. You have to go to the screen and properly see on the computer screen and evaluate layer by layer and space by space. And even for our referral cases, please send a proper interpretation of OCT. I will resume these things again. Thank you for your comment.
Thank you, Dr. Dereje. I have additional thing to add.
I have a comment here.
Yeah, okay, Dr. Jibat. Okay, go ahead.
I have seen some issues with our practice here. Even recently, I found an OCT with a printout with artifact. So one of the problem is, we don't, I don't see usually a raster scan of OCT with finding. So if there is a finding, let's say if there is subretinal fluid, at least we have to have 4 or 5 raster scan of that lesion. So we need to give a printout through lesion, raster scan through lesion of the OCT. So I think giving raster scan, can help, in solving some of the issues raised with Dr. Dereje and Dr. Abba.
Yeah, thank you, Dr. Jibat. Actually, OCT for macula and for optic disc is really different. The OCT for optic disc head analysis is really very self-explanatory, and really it hardly needs some interpretation, as you can see. But for macula, I think the comment is well accepted, Dr. Ababa, and I think we should follow the fact that, like, Dr. Dereje was clearly showing that we can easily miss the findings. So I think those who do OCT in their private practice, whatever, they should give with some either, as Dr. Jibat said, raster scan, just detailing the lesions, or else commenting as per for CT scan or MRI. I think really very important, and that trend should really go very clean.
Dr. Sadin?
Yes.
I have a
Dr. Malik, okay, go ahead.
Yeah. Okay, thank you. I just would like to thank OSE as well as Dr. Jibat, Dr. Dereje, Dr. Sadin for this nice presentation. You just gave us the basic of OCT, which is very important for the management of ocular disease. So I just have to just want to add a few points. So with the macular edema as well as this the choroidal neovascularization, we see such kind of conditions in young patients. So just the topics now, it is an introduction, and it's just focused on diabetic or AMD, but similar features can be seen in inflammatory conditions. So whenever you see patients with macular edema or chorioretinal, just neovascularization in those young patients, we have to look for just posterior uveitis, or just instead of giving injection, we have to work up them for uveitis. So there are a lot of use of OCT in cases of uveitis. In hyperreflective lesions on the retina, in addition to the infarction of the nerve fiber layer due to arterial blockage, we can find such kind of lesion in retinitis, but in that case, it would be a swollen one. So these are few points which I want to add. Thank you so much. And for Dr. Ababa question, yeah, it's very important to have just, not only print out with a paper, it's very important to have CD of the image with video. So in that case, the one who sent can see the, just, the OCT result just with the video. And just when you have got some, something to see on the OCT, you have to specifically just give a drawing which you want to have the scan of that lesion also. So these are few points which I want to add. Thank you so much.
Thank you, Dr. Mabit. Maybe Dr. Dereje or Jibat can answer. How do you identify inflammatory conditions, edema, versus non-inflammatory edema in the macula? Is there any points that you want to summarize on that specifically?
Yeah, yes, especially with posterior uveitis, usually we find bacillary layer detachment. So there will be splitting and inflammatory deposit in the outer retinal layers, apart from other, clinical finding. So usually we see a bacillary layer detachment and inflammatory deposit.
Okay, nice point.
So additionally, also you have to look for also these hyperreflective materials, which are maybe origin of inflammatory conditions. And also clinically, what you see on your fundus examination, depending on that you order OCT. So patient maybe with toxoplasmosis, they can have some changes in the nerve fiber layer. So you might reach into a diagnosis of that, but you do OCT to see layers involved, and for the follow-up of the patient also, treatment response and the like. So correlate, you have to relate clinical finding history and with the OCT finding rather than when we take into consideration the OCT reading.
Okay. Any other question, please, from? So just to keep the discussion, Dr. Jibat, do you think it is safe to do, what's the safety of these OCTs? Can you just really tell us the safety what are the common indications we should follow? Do we do routinely for everybody this OCT? What is your reading or what's your experience like in this case? OCT, do you really recommend for patients with apparently normal conditions, or do you think it helps in following the progression of the retinal conditions? What do you recommend generally?
So generally, there has to be indication to do OCT, okay, and there has to be clinical finding which is ambiguous to differentiate even clinically, and if you want a baseline documentation of the macula and treatment outcome, you can order OCT in such scenario. There has to be indication to order OCT.
So is there safety concern if we do on normal people?
No, it's not an issue.
There's no safety concern.
Yeah.
Okay. Any other question? The discussion will continue until 7:30, so we have 15 minutes to go. And you can raise any question from the group, please.
Can I
Sorry,
continue?
Dr. Sadin.
Yes.
In addition to what Dr. Jibat said, OCT can help us to diagnose in case a patient is having unexplained visual loss. Like when you do fundus examination, macula or retina looks fine, but patient is having poor vision. So by doing OCT, you might see inner layer atrophy or RP changes, something like that, which can reach into a definitive diagnosis. By that, you can convince your patient. And the other thing, we have to be meticulous that if a patient is having a media opacity from cataract, or vitreous hemorrhage or from corneal opacity, OCT has many place. Don't waste your time or don't cost your patient for OCT. It needs a relatively clear media, safe, and there is no risk of any ray or something like that that can restore patient. It is a safe imaging technique.
Okay. So you're discussing, Dr. Dereje, you're discussing about amorphous and consolidated subretinal hyperreflective areas, and what's the use of classifying those lesions as that?
So finding such a lesion, if it is amorphous and the like, it means that it's a fresh or active CNV, a fresh and a new one. So such patient will benefit from our anti-VEGF. If it is consolidated or become more hyperreflective, it is organized for subretinal hyperreflective material, which is choroidal neovascularization scar. So see, this scar will not respond to our treatment. So this is good to predict the prognosis and to choose which patients are a candidate for our intervention. So it's a way that you differentiate between active CNV from inactive CNV.
So that's a very easy way to identify if the lesion is active or not. If it's amorphous, irregular surface, so it's not well delineated, so it means the lesion is active. It's never it's not consolidated, so you can go on treating. Sometimes you just stuck between consolidated or not, treat or not. So sometimes not necessarily having some fluids, some shape of the lesion, subretinal hyperreflective area shape
Yes.
itself can guide you for treatment, you're saying, right?
Yes. So in even those uniocular patients, especially, and the more educated or aware people, even they can present early at the time of when choroidal neovascularization starts. So this can be detected with further advanced technology, fluorescent angiography, OCT angiography. By that you can appreciate choroidal neovascularization without leaking or without having such a membrane. This patient, other patient with amorphous, they are not still starting to leak, but the choroidal neovascularization lesion is there. So this is the time to start treat before they develop leakage. By that, the prognosis is very good. Size of scar will be small. Outcome is better than the one who is having late presenter.
Okay, thank you, Dr. Dereje. So the quiz is already forwarded. Dear participants, please take the quiz. You can click on the link and take your quiz and submit it accordingly, please. So thank you everybody for participating, and thank you presenters, Dr. Dereje, Dr. Jibat, everybody for participating and for the nice presentation. With this, I would like to close this meeting. Thank you very much.